All right, we're back, and this time it's going to be a very short Thursday. We've got 6 short studies on the docket today, and all of them are pretty much straightforward except one that I will elaborate later. First up, anterior epidural fat as a diagnostic marker on MRI imaging for differentiation between two types of lumbar spondylolisthesis. Boy, is that a mouthful. So what are we looking at? First is the condition. Spondylolisthesis is essentially a physical displacement between two vertebrae on top of one another. So depending upon your reference point, we can either have, let's see, where's my recording? So if we are here and we have two vertebrae stacked on top of each other, we can either be anterior, so anterior listhesis, so one is slipping forward, or retrolisthesis, where one is slipping backwards. And this is one of those things where, depending on population, age, etc., it is actually not that uncommon. Especially in sports, we see a lot of they're idiopathic and oftentimes isthmic, where there's actually either a fracture where part of the spine Lincoln logs together, like a hairline fracture, or there's a non-union. Basically, there's so much continued motion going through the vertebral segments that as the person is developing and growing, it doesn't completely fuse together. Now, is that really a cause for concern to take your kids out of sports? No. It's just something that I have a talk about when I'm seeing high school athletes that have this typical pain presentation pattern. It's like, hey, I can do a great job, get great info, and we make trial of care before we consider anything. But I should tell you that something that is a possibility given their son or daughter's sports, whether it's tackle football or gymnastics, they have a higher prevalence of developing this spinal condition, which again is not a doom and gloom thing or a reason to pull your kid out of sport. It's just a consideration like anything else. I mean, life is messy. I mean, let's take some sports like dirt biking. Are we going to take them like, well, there's a higher incidence of bone fracture, of concussion. That has long-term considerations. Are you going to take them out of that? No. Basketball, they can still get hurt, break bones. They can still get concussions. Not a reason to really be concerned, just a reason to consider certain presentations and pathologies when you're treating these people. But back to the study. So we have this condition, spondylolisthesis, that we can detect on MRI. So how do you differentiate between one where there's an isthmic or vertebral hairline fracture or larger fracture between the two segments versus one that has just happened from age and is degenerating, and that's the reason that it's starting to slip? Well, these researchers wanted to take a look at if a certain anatomical finding distinguishes one type over the other. That happens to be anterior epidural, so on top of the dura, in front of fat, which you can detect on MRI. MRI is very great for soft tissues. So what they found is the presence of this anterior epidural fat is more indicative of the isthmic type of spondylolisthesis. It was very sensitive and pretty specific. So basically, it was pretty good at detecting it in the first place. And then if it was there, it was like 74-ish% of the time, it was because of the spondylolisthesis, the isthmic spondylolisthesis. So just a fun little thing that we might take a look at when considering an MRI. If this is there, not only could we say you happen to have a spondylolisthesis between the two subtypes, if we have fat or not in this space, we might be able to say it's one over the other. Now, next study. Relationship between the impact of tinnitus, or that constant buzzing, ringing, annoying sound in your ears if you have it, and craniofacial and cervical disability, dizziness, and emotional symptoms in individuals with TMD, or temporomandibular disorders. So they really found that after studying a small group of people, that to no surprise at all, the more conditions that you stack up, the more likely you're to have more conditions. So basically, if you only had, let's say, TMD with no headaches, or TMD with headaches and no tinnitus, the more you add, the greater the impact on disability. But I think they say better in their conclusion, or sorry, their results, than even their conclusion. Here we go. Individuals with temporomandibular disorders and tinnitus, so that ringing in the ears, have higher prevalence of additional cervical disability. So again, where there's one, might be another. Where there's two, there's probably more. They also had a higher prevalence of dizziness-related impact and a higher prevalence of depressive symptoms than those who just had TMD with no actual tinnitus. So again, I want to take two approaches to this study. The first, or the study in reference to its conditions. The first one is one thing that you have to consider, especially when you're treating people like those with autoimmune disorders. One thing that I was taught, and one thing that you do see if you've been doing this, is that where there's one zebra, there might be another. Or put another way, if somebody already has a condition, they are already in a higher risk category to develop another. So when somebody is coming in and they already have a temporomandibular disorder, they're already in a higher category for having other conditions because of how, this ties into the second, how connected that region is and how much interplay there is between the jaw, the neck, and other sensory symptoms like hearing and tinnitus, between some perception. So some people, there's enough overlap between upper cervical musculature, joint connections, etc., that they can develop things like cervicogenic or from the neck-based vertigo. These musculoskeletal conditions overlap a lot and influence conditions not only including cervicogenic vertigo, but like this one talks about, influences tinnitus, influences, to some people, they claim it influences sight clarity and sharpness. And there is some anecdotal and potential mechanistic reason to why, but not enough to really state that from an intervention standpoint that treating the musculoskeletal system will give you really an edge in ocular tasks. But if I tie everything back to the study, so you already have TMD, now you have TMD, and you add tinnitus in there, well, we just covered how much interplay there already is in this region. It is therefore no surprise that if this area is interconnected and potentially sensitive to feed things back and forth, that if you have TMD, but now you have TMD and tinnitus, the odds of you having additional symptoms, issues, or disabilities within this interconnected region, they skyrocket that much higher. So this really shouldn't be that much of a surprise and really lends itself to saying you really need to take a whole person approach to treating a lot of these conditions, especially when there's a lot of overplay and interlap, and it may be consideration for calling help treating this person from multiple angles and via a biopsychosocial model. Because for me, I love taking care of what I'm great at, but because these people may have additional depressive symptoms and develop other, let's say, emotional triggers where I might be able to get them 60% better without, actually truly taking care of the emotional side, I can't actually resolve the rest of the issue. Great time to refer them to a relevant healthcare practitioner. If it's an athlete, have them see a sports psychologist. Uh, this is just more reason to have interplay between providers to tackle all aspects of these conditions that even if a single one is straightforward, multiple ones can get a little bit messy, and generally the human condition shouldn't really ever be considered to be taken care of solely by a single provider. Like, love your primary if you have a great primary, but they are not the be-all end-all, nor am I. Even if you would consider me somebody that's taking care of a majority of your issues, I'm not the be-all end-all. Anybody who claims they are, who claims they're a panacea, claims that they're able to treat the entire human condition via 1, 2, or 3 treatments or some weird guru-ish approach, run to the high heavens. Okay? That's not to say somebody like myself, I treat nutrition, lifestyle, and exercise. That has huge effects across that human condition. But I also know that it is not the entirety or the breadth of what a person can go through in life. So, next on, before I get on a high horse, this one. Early anterior cruciate ligament reconstruction is associated with decreased risk of osteoarthritis compared with delayed reconstruction. So, I actually had a conversation with a patient who had an ACL tear and was considering repair last week about this. Surgery versus no surgery. Really, it comes down to a combination of factors, including age, goals, level of sport, and lifestyle dynamics. So, if you rupture your ACL, do you necessarily need to go in for a surgical repair? Not necessarily, no. There are a lot of people performing at relatively high levels without an ACL, and many that don't even know that they actually have a torn ACL and they just happen to find one. So you can truly go the entire conservative route if you wish for ACL tears. There is a level of later in life surgeries that patients opt into because they develop a sense of instability after a period of years. I think the incidence rate for that was like 20 to 50% of people who didn't get this surgery within this window we're talking about, so they delayed it 5, 10, 15 years, eventually elected to get the surgery to add a little bit of instability later in life. But again, considerations for surgery should be an open discussion between the patient, their goals, their lifestyle, etc., to see what is truly best for them. So I did a lot of pop and circumstance and tried to lay the field work between, do you really need to have a surgical repair for an ACL? Technically, no. So when is it warranted and why do we do it? Especially in the younger athlete, because we also see that surgery doesn't really seem to stimulate early osteoarthritis, especially in these windows. If you're returning to a higher level dynamic sport or activity, let's say a sport that requires a lot of cutting or change of direction, so you're returning to soccer or you're returning to basketball, um, basically most any sport, if you're wanting to return to it and you're younger than, I think a lot of the studies are in the range of sub 40, 45-ish. If you are sub 40 or 45 years old and you're returning to a modest level or even a higher level, moderate level of sport or activity, you can consider, and it may be in your best interest, to get an ACL repair. There are several different ways that they can go about it, which I will not get into in this video, between where they graft the tendon, between within your own body versus a cadaver, and there's pros and cons to all approaches. Suffice to say, have a conversation with somebody like myself who manages the conservative route to paint you a picture of what that would look like. Also make sure that if you're going that route that they don't just rely on time frames, because ACL repairs, whether they're, especially if they're surgical, but even if they're non-surgical, have somebody measuring your body and what it's doing, how it's compensating, to give you better actionable insights to hit better time periods for recovery and repair. But that's beside the point. Where was I? So if you're sub 40, 45, returning to high level sport, we shouldn't really have to consider or worry about osteoarthritis with early intervention surgery. And really, there's a pretty consistent time frame if somebody's measuring things like we are with force decks and dynamometers and inclinometers to return you to a pretty decent level of sport at an appropriate time point for you. That's when you should really consider a surgical route. When not to consider a surgical route. Again, if you don't have aspirations for high level athletics, if you are getting into an age where, again, where the studies have these somewhat of a cutoff is like that 40, 45, and some are 50. But if we're getting into that age category where the return on investment for going through the surgery, which has its own risks and complications, even though it's fairly standard, do not necessarily outweigh the benefit you're going to get from just rehabbing it yourself. Because realistically, anybody who has a tear should be going through some sort of pre-op, rehab, or prehab, which means you're already prepping the tissue to make sure that it's robust going into the surgery to give you a better chance of outcomes afterward. And then you're going to have rehab no matter which route you take, whether it is surgical or non-surgical. So the reality is the only difference between the repair and no repair is just the fact of if there's a surgery or not. You're already going to go through a whole bunch of rehab and getting better, stronger, etc. So I like studies that give us reassurance that people that opt to go the surgical route, especially in these time frames, which again, I'll just double check because really the point of this video is to talk about this and not just hear my rant about ACL repairs, is to show that some joints and some surgeries do show higher incidences of osteoarthritis. However, if we catch it, we go to this one, we knew that within a month showed 10% reduction in osteoarthritis, but there is a huge impact that people see if they get surgery within 6 months of the injury. So that's right, you heard that right. If you tore it, your body usually, not always, but usually will know it. You find out you have a tear, you're debating surgery, and they can't schedule it to get in within a month. Are you SOL? They find a big impact if you can get it within 6 months and within 12. So really that's what they look like. What are the incidence rates for osteoarthritis after a follow-up for patients that got surgery within a month, within 6 months, within 12 months, or after 12 months? And there's really big spikes after that 6 and 12-month mark for developing osteoarthritis comparatively if you would have rather gotten the surgery beforehand. So you've got time. Don't think that you have 2 weeks, 4 weeks, and you got to make this decision just like that. Or if there's a delay in surgery because you want to take the time to prep the tissue going into the surgery itself, you got time. All right. But if you're interested in hearing me discuss more about surgeries as far as ACL surgeries are concerned, what to do, who to find, how to work with it, what tools and what measurements and what biomarker pre-op, post-op, or just pre-rehab, post-rehab, or post-injury, I should say, comment this video or send me a message, all right? But I want to move on because I want to keep this short. So this one, I think I can keep this one relatively concise. Just let's make a promise. Let's not get too ranty here. Central sensitization severity in chronic low back pain and its associations with sleep, distress, cortisol, and visual spatial working memory. So first up, central sensitization. Basically, there's a couple different analogies that I could use. If we take a look at low back pain and the pain aspect of that, if we take the body and we break it up between hardware and software, this will be my first analogy. The hardware is essentially the part or component of your body that's sending the signal to the software. So you have the low back area, whether it's the bones, the tendons, the joints, the ligaments, whatever it is, the hardware is having a bit of a blip. So it sends all the information that hardware does to the software, the programmer, the thing that has the checks and balances. This software then goes a little bit cattywampus, gets a little overzealous, or gets a little overprotective. It dials up a bunch of your body's different protective mechanisms. One of those is pain. So if you're experiencing some pain and it gets there long enough for the central processor, the software, the brain to go, oh, this is going to be no longer a bug, but a feature, now going to dial things up. So even if the same signal was being sent 6 months ago as it is today, your body, your brain will amp it up because it wants to protect, because it says it's been there so long, there must be an issue. And now, rather than being a bug that we got to pay attention to, this is now a feature that we have to focus on and emphasize. So now anything and everything may set it off. Or, was a poke here, an annoyance, central sensitization may go, oh, crud, that area's been injured before, all hands on deck now, and what should just be a little poke is like, oh, holy Moses, that is really painful. That's central sensitization in a very poorly put analogy. So I kind of already laid the groundwork in the sense that this central processor and this software are ramping up your body's overall protective mechanisms and are reacting. What are some downstream effects of that? Let's find out. Let's go right to the results. So compared within this study group, so they had a control group, a mild central sensitization cohort, and a high central sensitization cohort, which they found through various surveys and other measurements. They even included some biomarkers, which they actually found didn't have an impact between groups. So let's look at the results for this, though. Compared with both mild central sensitization patients and their controls, the severe group showed markedly poorer sleep quality and higher levels of psychological distress. Why? The central unit, which controls those things anyway, is now on high alert mode. So you're not as likely to get good sleep. You're not as likely to be in a good frame of mind. They also found one of the biomarkers that actually did stand out was morning cortisol concentrations were significantly elevated only in the severe central sensitization group. So again, it is bad enough that the body is recruiting other areas of your body to stay on high alert. Whereas no statistically significant differences were detected for other biomarkers such as fasting blood glucose or interleukin-6 between groups. Healthy controls outperformed both when it came to certain subtasks in this research, indicating reduced working memory in patients with any level of central sensitization. Shocker, if your brain is shunting resources to take care of a perceived problem, it doesn't have as many resources to work with for things like memory. Whereas no differences were observed in planning tasks. Kind of similar to the tinnitus and craniofacial stuff. This really warrants a whole person approach, and we really need to make sure that on trying to treat the hardware, we make sure that through education and through other means, we make sure that we're treating the patient's software. We do that to the best of our ability, and we must recognize where that may need additional modification from another healthcare practitioner. And I sincerely hope it's the vice versa. Somebody working on the software, when there may be a hardware issue, will send them out, refer them out to the appropriate provider. Oh, right. Is there anything else that I wanted to talk to you about? I don't think so. All right. Well, until next time, group, thanks for sticking with me. And if you have any suggestions or want to know more or have anything in particular you want me to take a look at, please reach out to me. As much as it doesn't always seem like it, I do actually enjoy some of this and keeping things up to date, sharp, and being able to explain these things to you. So one last time, thank you.